Here we present a case of endovascular embolization of a type 4 dural arteriovenous fistula. The patient is a 56-year-old gentleman with history of progressive right temporal occipital headaches associated with tinnitus, vertigo, nausea, and vomiting. CT demonstrated hyperdensity on the right temporal occipital region and T2 imaging prominent phleboid suspicious for fistula or AVM. Digital subtraction angiography demonstrated a type 4 fistula that was fed by occipital and middle meningeal arteries. You can see in the venous phase the significant cortical reflux and drainage into the superossetal sinus as well. We offer a endovascular embolization procedure through a transarterial approach, and under conscious sedation and access to a right femoral artery, a 6-range catheter was navigated into the proximal common carotid artery. Observe the anatomy of the fistula. In this lateral view, you can appreciate the nidus and the venous pouch of the fistula. On the road map, we also navigate an intermediate catheter into the maxillary artery. We like to use an intermediate catheter for more support, especially in these very tortuous vessels. Once we have the intermediate catheter in the maxillary artery, on the road map, we navigate the microwire and microcatheter through the enlarged middle meningeal artery. Here we have two different branches that are going into the fistula, small and the big one. We decide to go through the small one to have a plan B and the large one as a backup in case there was some reflux into the small one and we're not able to get access into the fistula again. Navigating into the fistulous portion of the fistula is key to obtain a good embolization. Sometimes it's not possible. However, in this case, we were able to navigate the microcatheter into the nidus of the fistula itself. Here's an AP view of the microcatheter getting into the nidus. A microinjection angiography is performed to confirm the location of microcatheter, making sure that the catheter hasn't gone in through the venous pouch through the fistula. We are happy with the location of microcatheter. We prime the microcatheter with DMSO, but followed by a slow, steady, pulsatile injection of the onyx embolic agent. Observe the onyx going in through the different channels of the fistula and into the venous pouch. We want to inject the onyx in a continuous, steady pace, allowing penetration of all small branches and the fistula itself. We have to be careful and pay attention into the transverse sinus and observe if there is a liquid embolic agent going into the sinus and stop. We don't want any sinus embolization. Observe how the onyx is finding all the multiple channels of the fistula. And now we have some reflux into the large major branch of the middle meningeal artery. And that's okay. That's what we want. It means that the fistula has been embolized successfully and now is finding an arterial route. Immediate post-embolization injection demonstrates that the fistula has been completely obliterated. Another injection demonstrates the same, and then slowly we withdraw the microcatheter. Observe how the middle meningeal artery and the occipital arteries remain intact. However, there is no more venous shunting, and the fistula has been successfully treated. The patient remained neurologically stable throughout the procedure and was discharged home the next day.